Welcome to our Behavioral Health IDD Working Group meeting. My name is Kenya Servia. I'm one of the Business Development Outreach Specialists at the North Carolina Health Information Exchange Authority. Today's meeting is being recorded for those providers who are unable to attend, as well as those of you who are in attendance, so that you can go back and review today's materials. If you have any objections with being recorded, you're welcome to eject from the meeting, and we'll be glad to send you out the materials. So our agenda for today, we're going to start with welcome and introductions, and then following that, we're going to have Carolyn Spence, the CIO from Alexander Youth Network, give a perspective from a use case, and then we'll have Jerold Greer, the CIO from Daymark Recovery Services, share his perspective of utilizing the clinical portal. And following that, my name again, Kenya Servia. I'll be sharing with you our connection process, reviewing our participation agreement, the welcome packet, patient education materials, as well as some of our key policies. In addition to that, I'll be explaining to you our event notification, NC Notify, and demoing our clinical portal. With that, again, we also have a new team member. I'm not sure if he's on the call, but Luke Keeler is our newest business development and outreach specialist. Luke, if you're here, would you like to say a word or two?
Yeah. Good morning. Can you hear me now?
Yes, sir.
Well, that's great. Well, hello, everyone. My name is Luke Keeler, and I'm one of the newest additions to the HIEA, and I am now part of the business development and outreach team. I'm very excited to be here to learn from all of you and hopefully be seeing you in the future.
Awesome. Thank you so much, Luke. Carolyn, I'm going to unmute you. It might be easier to hear you that way. I don't know if it'll cause feedback.
Morning, everyone. So that was a fun little exercise. Let's go ahead and get rolling with this a little bit. I want to talk to you about Alexander Youth Network's experience with using the HIE tools and stuff. And I'm actually going to, not to ignore the rest of you in the room, but I'm going to point my face at her computer so everybody can hear me very well. Kenny, if you can move to the next screen. So as everybody, as Kenny kind of introduced earlier, I'm with Alexander Youth Network. We're a child and adolescent behavioral health provider in North Carolina. We've been around since 1888, and we serve, about 10,000 children annually in our services. We have about 25 offices across the state of North Carolina, and our array of services goes from residential services, therapeutic foster care, day treatment, community-based services like intensive in-home multi-systemic therapy. We offer outpatient and med management and all that stuff in between. And we receive referral sources from everywhere. So we actually benefit quite a bit from the information that we receive from the Health Information Exchange. So just wanted to highlight some of the challenges that we have, and I don't think that we're the only ones that have these challenges, but when we're bringing in a new client or we're having to do an assessment and stuff like that, we're having difficulty sometimes getting the information from the referral source. You're trying to assess what are their needs. You don't know their medication. You don't know their past treatment history. You don't know if they've had diagnoses before by someone else. So those have been some challenges that we've had and been really, trying to figure out good ways to create some efficiencies for our staff. The other thing is that we recently became a tailored care management agency back in December, and everybody knows that since COVID started, the recertification process for Medicaid discontinued, which means a lot of the information and contact information for Medicaid consumers is not easily available in certain systems. So that's been a challenge that we've been able to leverage the HIE for. The other thing is we have a lot of clients that we serve on an outpatient basis, and being able to know when they went to the ED, the emergency room, or inpatient is something that we were trying to figure out. How could we get more real-time information on that? How can we get in front of it? How can we get kids out of the hospital sooner and stuff? And then, along with that, mind you, we've worked with children in behavioral health services. We don't have as many HEDIS measures that really pertain to our population, but we do have some, and one of those being follow-up after hospitalizations or ERs. And then understanding all the medications that the youth are on and being able to track that. So those were some, some challenges that we have. We can imagine when we do an intake and we bring a client into services and they're sitting there talking to the therapist, they're in a crisis. They didn't bring their history of information. They didn't bring what's going on, and being able to gather all of that information and really work and understand what's going on, but also put the family at ease with the whole process. Definitely was a challenge, because making decisions of what the next step in treatment would be was difficult within some of the information that they couldn't always present, especially when they're in a crisis or something going on. They're focused on the here and now, what's going on, not what happened in the past. So how we got started, just we started this process back, I think, in 2017, where, and it's kind of the same process that everybody has today. The first step is, getting the full participation agreement to connect to the exchange. So you just need to, you actually can pull that down off the website. Kenya's going to go over that in a little bit. But essentially that was the first step, was, sign that full participation agreement, working with the team at SAS, because they're the contracted provider for the health information exchange, to help us try and get connected, help us get our logins, help us, understand the tool for the health information, or NC HealthConnex. And so some of the information that, we were lucky to be able to leverage was information like increased access to their, our clients' physical health information, their lab results. I mean, that's huge, especially when they're coming in from med management and trying to really work through what medications are they on and all that stuff. Immunization records. We work with children, and so we need to know what immunizations they have. That's very important to make sure they're up to date, help us understand if they have a primary care physician. That's huge. And so we want to make sure that we're working with the families, that we have up-to-date information. And we were able to use HealthConnex to get some of that. And then summaries. I think this is huge. And I'll talk a little bit later about some of the things that we've done with summaries in the clinical comprehensive documents that were received that are available on HealthConnex for us. They've been very helpful in helping us mitigate some issues where family didn't understand discharge medication. They brought old medications in instead of new prescribed medications. And so some of that has really helped us make sure that when they're discharged from an ER or an inpatient, that we're able to connect that a little bit better. All right, so I'm moving closer to the mic. Hopefully this is a lot better. So, and I'll raise my voice. It's going to sound like I'm yelling in the room, but that's fine. So the other thing that we did after we connected to the HIE was, we worked through the process to complete our enrollment form for the NC Notify tool that the HIE offers. And essentially that's just where we receive notifications regarding admissions, discharges, or transfers within service providers. So it gives us more real-time notification when kids go to the ER or inpatient events that occur. And it also gives us some insight into ongoing outpatient events that our population is having. So we're able to see, are they going to their primary care doctor? And we're able to use some of that data and bring it into our EHR, which creates alerts when we don't see that that stuff is happening. And as you can imagine, because we're getting that information, we're able to intervene quicker. That allows us, to call the family right after an ER visit, or to call the family and the hospital after a youth has been admitted. So right away, so we can start that transition planning and get them out of the hospital and back into lower levels of care. So they're returning back to the community setting. And so ultimately, that's been a great resource for us. And it's, as you can imagine, huge. If we can get kids back in the home or back into the community, that means that we're helping them out, and that hopefully they're going to, their outcomes will be better and be able to return back to public school and not require those higher levels of care as often. So here I'm going to talk to you a little bit about how we use it at Alexander Youth Network, and I'm probably going to go off script a little bit, but the first thing that I have here is our facility-based crisis. And so we tend to just get, families and clients who are in crisis, and they'll show up at the unit and they need services right away. And they could be referred by another hospital setting. They could come under, sometimes families contact the police officers to help them bring them to the facility. So you can imagine those families are in distress, the clients are in distress. And so having to sit and gather information for a couple hours to know what's going on just so that we can get started with the client can sometimes, be challenging. And it doesn't give the family, when you're asking questions over and over and over again, or you're probing for things that they can't answer, it gets a little frustrating for them, and they're wondering, when can I get started? I just need him to get treated, or him or her, their child to get treated. And so that's been since we opened our facility-based crisis, our team there makes it a regular part of their process to log into HealthConnex to gather information on the youth that's coming into the program. They're able to talk about those things and engage the conversation where the client is at. So if they've already had services at an inpatient facility, or they have a doctor involved, or they have other diagnoses, or they're on medications, they can start there and have those conversations with the family. Instead of it being a constant probe, it becomes more conversational, and then the family starts to relax a little bit, and it helps them move into the program. So that's a little bit about how we're using a facility-based crisis. I did talk a little bit earlier about how we became a certified tailored care management agency, and some of the challenges with the Medicaid recertification and the contact information not being up to date. And our team of care managers actually leveraged the HealthConnex environment to see if they can find additional phone numbers or addresses that might be more current if those kids have had treatment with either their primary care doctor, or in a hospital type setting, or just any ongoing therapies that they might have had, where the information is being shared with the HIE. And so that helped us be able to contact more clients, because the information that we would have received upon referral was not necessarily up to date. And so it became a nasty little cycle of trying to gather that information to get them engaged. So it was quite helpful doing that. Also, I think I touched on the medication reconciliation piece. We had, we've had a couple opportunities where our youth have discharged, whether it be from inpatient or from an ED, and medications were changed during those short events. And then when they returned back to the program, there was some disconnect in understanding the medications. So the clinicians in the programs and the treatment team that were working with them when the kids returned back to us, they were able to work with the family to help them better understand the discharge aftercare plan, because they had access to it. They knew what they were prescribed in the hospital or in the ED, and they were able to talk about the interventions that were provided and really help educate the families on how to administer those medications and how to understand. It can be difficult if a medication has increased when you're in the hospital and the doctor just says, oh, take the medications that you've already bought, cut them in half, and then do 1.5 of those. Sometimes that's a little difficult to transfer when you put it back into, I'm going into the home. Yes, I'm still having issues trying to, correct the behaviors and stuff like that that might be occurring. And so it was an opportunity for our team to become a little bit more engaged with that. I also talked about primary care physician. It's a population where sometimes they go see the doctor on an annual basis, sometimes they don't. And so we wanted to get more in front of that and make sure that we were really working with our families during our treatment team meetings and stuff like that to make sure that, one, they had a primary care physician identified, and two, when was their last visit. And we would be able to see that through HealthConnex And if they hadn't had one, we would help the family get one scheduled so that we could at least get the physical needs taken care of while we were working with their behavioral needs in the programming. And then transitioning the youth out of care, and that's just, you know, when they're inpatient or ER visits and stuff, you know, especially when when a youth has a crisis and they have to go inpatient, they could be there for a long time. And part of that has to do with the resources that are available, the step down resources. Is everything going to be met? Well, if we're already engaged with the youth and we're working with them, we know they went inpatient, we're really going to work with the hospital from day one, because we received that admission notification from NC Notify. So we're going to work with that hospital from day one. We're going to start talking about what are their needs. We're going to look within our continuum to see if we can meet those needs and step them down to the hospital, or we're going to work with other providers in the community to help make sure that their needs are met. And because we're starting that from day one in their hospital, we're able to shorten their length of stay in a hospital setting versus having, you know, getting engaged at day 14 when the team is like, okay, they're stabilized, it's time to discharge. We all know that those transitions don't happen very quickly to other providers. And so getting involved quicker definitely benefited the families and the youth, because that meant they had the best discharge plan in place that they could have. Can you push forward? You know, the other thing that I kind of have a dashboard, just a screenshot of a quick little dashboard up here. And this is just more or less giving some more visibility to us, because we get the notifications from the HIE through NC Notify. We're able to now understand, are we interacting with the youth upon discharge from the ER and the hospital? Are we getting them what they need quickly? You know, a lot of outcome studies have showed the sooner that they are engaged post discharge from the ER or the hospital, the better their outcomes are, the more they adhere to treatment and stuff like that. So we just want to make sure that our programs and our staff understand, are they making timely, are they engaging families timely after those events? Are they getting into the home, or are they bringing the client into services to do some face-to-face interventions and really help them through what just occurred during that crisis event? So this is just a little bit of visibility. I just wanted to demonstrate that, you know, this information is not only powerful to do one-off interactions, but it kind of gives you a whole of how you're doing as an organization or doing as a team to meet the needs of the youth to help them stay on the right path. All right. And then, you know, I like to end off just by saying, you know, kind of outlining a little bit about what this has meant to us as far as an organization and being connected to the HealthConnex portal and stuff, and receiving the ADT. One, and I've mentioned it several times, is those timely notifications. Those are vital. Those are important, not only to us as an agency for some of our measures, but also for the families. They really appreciate having somebody who they have a relationship already with, spending some time talking to them and letting them know what the next steps are, helping them understand their discharge plans, helping them understand what they need to do, and then really working with them through that process. So that's, you know, not only brought awareness to us, but brought awareness to them. The physical health needs, we are a behavioral health provider. We tend to deal with those behaviors, and we deal with them very well. That's where we excel. Those crisis events, those behaviors, that's what we do great at. And a lot of times we don't often know those physical health issues that present with our youth. And, you know, ironically, before we got connected to the HIE, we might know a few cases of asthma, a few cases of diabetes, but we didn't know the extent of some of the other health issues that our youth had and stuff. So it was an eye-opener when we were able to get more insight into what was happening with them physically. And then it helped our staff through, you know, because some of that also, kids don't feel comfortable expressing what's going on with them. So it gave us an opportunity to talk it through, let them know, you know, put it in more clinical terms, help them understand that it's not an impediment, that they, you know, don't need to, feel like they're alone and stuff like that. So we've been able to work through some of those. It also helps our doctors when they're prescribing medications to understand what other things are going on and to have more real-time information on that. And then the other thing is to monitor and identify patterns. So one of the things that we noticed early on, and the reason why we spend a lot of time focusing on primary care physicians, is we noticed that a lot of our families, especially in one area of the state, were using the ER as their primary care doctor. And so they were going there to get their medications changed. They were going to the ER to have their physicals done. They were going to the ER for simple stuff that they could have scheduled an appointment for and been on a regular schedule with their primary care physician to get those needs taken care of. And so we were able to work with that community and really help identify primary care offices for those kids, get their families set up with appointments, and stop that use of the ER for those medication visits. So it's interesting when you start seeing those patterns and things that you can do to help them get more regular care in place. Linking and referring clients to services, that's huge. So understanding where they've been, what they've been doing, and what interventions have been effective or that they've had in the past is important. So we have actually been able to engage with past providers and really gather information that might help with the next step in treatment. So it's helped out a little bit with that. It also helps us when we bring kids in, we have a better understanding of what their needs are. And we're able to engage with the families better. I kind of outlined that already quite a bit. And then treatment adherence, that follow-up after treatment is huge, and it really helps make sure that we're keeping the families engaged with us, and our team of professionals or our clinicians are actually understanding more about what's going on and really giving the family the information that they need. So we're seeing more of a partnership between our treatment providers as well as our families. And so, some of those little things that you don't think of when you use a tool like this or have access to this data is very vital in that engagement is huge, but that need to feel like you're part of a team really goes a long way to moving our clients and their families through care. And I think that's it for me, but I'm not sure if there's any questions. Okay, so if there's any questions, are you going to open the chat, Kenya, or are you going to?
If you think of a question for Carolyn later, we do have some time toward the end of the meeting for additional questions. But if you do have questions now, before Jerold begins his presentation, now's a great time to pick Carolyn's brains.
There was one question that come in. It says, can you share what prospective patients and families have had regarding the North Carolina HIE? And so I think when our folks gather the information, the perspective has been, it feels a little bit more like it's a continuous care. I guess what I'm trying to say is they feel like know what's going on and that they don't have to define it for us, that they're grateful that the information is available and that it helps, the conversation move on. Every once in a while we'll get a question, hey, how'd you know that? And we're able to say, well, part of our process is that we share information with the North Carolina Health Information Exchange through an automated process. We don't go through all of that, but then we indicate that because we're sharing information, we're also able to see, how things are going and how you're working through treatment, which helps us better understand your needs, but it also helps us be able to communicate better with you. So they've been pretty receptive, I would say.
Carolyn, just quickly, I'm working with the team in the background. There's another question in the chat around how you receive notification from Precise Pediatric Associate. Okay, so the question was, how do we receive our notifications?
And so for us, there's two ways, and Kenya's going to go over this a little bit later, but I will talk to you a little bit about what we did is, so our process is we send a panel, which is essentially our listing of all of our clients that we serve to the HIE. We send that once a week. We send it through a secure SFTP folder. We send that once a week. They then use that information to send us back notifications. But they also, because we are sending information to the HIE, that information that we're sending automatically connects that client with Alexander Youth Network. And so even if we didn't send the panel, because there's already a relationship with Alexander Youth Network, they would send us those notifications. Those notifications, just so you know, come back to us via a CSV file to our secure SFTP folder. And we have set up automation to ingest that into our electronic health record. There are other formats where those files can be a lot more, and I don't want to get into the technology of the whole thing, the technical stuff, because it'll get confusing, but you can do it so it's a much more real-time relay through HL7 channels. We've been set up with the SFTP for a long time, and so it's working quite well for us. We will be exploring the other channels in the future, but right now that's where we're at. So that's how we get our notifications. I hope that answered the question.
And what Carolyn is referencing is our event notification service, NC Notify. That is the service that they're enrolled in to receive those real-time notifications. And
Kenya, I don't know if you can see it, but I'm watching in the background. There was a comment in the chat that I thought was interesting to point out. Not really a question, more of a comment. This was from Miss Huffman from North Carolina Psychiatric Associates. It says, "This was great. Thanks. I'll be interested in hearing from small practice professionals. These are the practices that don't have IT personnel or extra stuff to pull reports and search the HIE. Also, they are treating the paranoid adult patients who refuse to consent to share information." So I just wanted to share her comment with the group.
Thank you for that, Robin.
all right. Robin said we lost our SFT, a secure file transfer protocol. That's just another means in which they receive their event notifications, Robin.
Well, and I think it's important to also point out that
Good
the
job,
NC
Sarah.
Notify service, you don't have to do the SFTP. That's the protocol for secure file transfer. You don't have to use the HL7, which is the more programmed relay of information. You can actually, through your login to HealthConnex, get that portal. So let's say if you're a small practice, let's use your front desk type person. They could have a monitor up, and when you're logged in, there's a queue of all your notifications. And so it's just like a screen that would identify all the clients in your practice that have either gone to the ED, gone to the, or been admitted inpatient, and it'll give you discharge information and all that stuff, along with some other really cool alerts, like if there's any, I think positive COVID testing, and we don't use that portal as much, but it gives you a lot more, and I'm sure Tim and Kenya will go into that, but it gives you a lot more alerts on that screen. So if you're, like you said, you don't have an IT team sitting behind you to do all of this stuff, you could actually just use the HIE and have it up on a screen, and it'll just roll in the notifications for the different clients.
Yeah, that's a great point. And Kenya will cover that. For those on the call, Kenya will cover some of NC Notify at a high level, and Jerold may be talking about that as well. I'm not sure about how to touch it.
Well, and you guys will be talking a little bit because some of the folks are talking about how their patients don't want their information shared. So some of the, I think I'll let you guys talk to it, but that whole perspective is that they can opt out. But providers who are supposed to connect to the HIE should be sending the data, and then the patients themselves or your clients themselves can opt out through the HIE, and the HIE then
We suppress.
they suppress the data so other people can't see it, but they have to opt out with the HIE, not opt out with you as the provider.
Any question?
One other point.
Okay.
So this is Kristen Sappho to everyone. I'm also interested in hearing about informed consent. How are providers handling or telling patients getting consent that are giving and receiving information to the HIE?
I think that's going to be handled with, Kenya talks about patient education, but Carolyn, if you want to talk about how you're doing it within your practice, that's.
Yeah, so that's part of our release of information without consent disclosure that we have. And in our family handbooks, we notify them that we are submitting data to the HIE. When they have further questions, we talk to them about the North Carolina Health Information Exchange Act and that we're mandated to send the information. We also, through the link to the North Carolina HIE, you have stuff in there where you can ask. So we have asked for Spanish brochures and English brochures. And so we have all of those Spanish brochures and English brochures on display, and the families can take those for additional information on what they need to do.
Carolyn, because you bring up a good point. We also have our AHEC practice support coach. Thank you, Chris Weavington, for putting that comment in the chat. They are able to assist you with any HIE trainings, NC Notified trainings, and telling your patients or getting consent that they're giving and receiving information to the HIE. So again, thank you so much, Chris, for putting that in. They partner also with Medicaid to provide this service. So if you don't know the practice support coach in your area, there's an email for you to reach out, practicesupport@ncahec.net. And also more information on HIE and NC Notified services are online in their training modules that we have at the Health Information Exchange Authority. And those training modules, we can send those out on next Wednesday when we send out the recording from today's presentation, as well as the materials from today. They'll be sent out on next Wednesday. So thank you for that, Chris Weavington, and for your support and the team over at AHEC. With that, we are going to segue into Jerold Greer. If you'll just give us a moment for him to get his screen shared, and we'll be moving right along.
Can everybody hear me okay? I'll assume so until somebody chats that we need to make an adjustment. Now, Carolyn said when she started that she might go off script a little bit. I'm the kind of person that goes off script entirely. One of the reasons for that is that I do a live presentation when I do something like this. So I show what it looks like right now based off of the information coming in, and we just kind of wing it. And I think that's kind of helpful to see what the reality looks like. So just a little bit about Daymark at a glance. This is kind of our map where you're going to find bricks and mortars. And sorry, there's a little lag time in what we're doing, so I'm bouncing back and forth on the slides a little bit. We have psychiatric and med management services in over 25 counties, walk-in crisis services, what we call enhanced services with ACT, intensive in-home treatment, and so on, mobile crisis, 7 facility-based crisis units, 4 behavioral urgent care, and then tailored care management that Carolyn talked about across the state. And the presentation I'll be doing today will be a live presentation showing our EHR and HIE integration, and I'll just talk on a couple of other bullet points along the way that I think are pertinent to some of the discussion that has already been happening. We have about 1,000 staff across our organization, and we've, despite being a behavioral health organization, we've always had a whole person care philosophy. So we've used data from across the state from a long time to integrate information that we know about diabetes, hypertension, or any claims data available to help inform the provider to provide the best service possible in the context of the whole person. So when I get into the live mode, one of the things that you'll see is that our EHR is Next Gen Enterprise, and I'm not here endorsing an EHR, our EHR, Our platform has been highly customized by us, by our own development team. And it would actually take a long time to break down and say, well, this is what the EHR does, and this is what our enhancement does, because they are tightly coupled together. And that would just take a long time. So nobody go out and buy NextGen because of anything you see here today, because you wouldn't get it. But I'm not saying anything. It's just, I just want everybody to be aware that it's a lot of the stuff is our own stuff. Our implementation with the HIE is bidirectional. So our system is real time sending information to the HIE, and it's also getting information back from the HIE. But it's different than just the NC Notify interface that we spend a lot of time talking about. When I pull up a patient in the screen, then it's going to be a dummy patient, and information that you see within panels in the presentation is in what I call confidential mode. So there's real information filtering in, but it's de-identified for the uses like this. So tailored care management, and within tailored care management, the ADT feed for inpatient notifications and emergency department notifications are what are called triggering events within the care management program. And with triggering events, we have to take action. We're required to do reassessments on those members. So that information is very important for us, and also to integrate into their care plan, not just for engagement, but also to integrate whatever those findings are into the care plan. So we also leverage the HIE to create our own triggering events. So there's some things you wouldn't open the tailored care management manual and find directly, but yet we call them triggering events. For example, we leverage chronic condition alerts. So through the HIE, we might discover that someone has hypertension or diabetes that we didn't know about before, and it's telling us that. So in our data mining operations, we'll discover that through analyzing the data and notify care managers, and that then becomes a triggering event. And you'll see what that looks like as we make our segue. And this is my segue slide to say that I'm going to stop with the presentation here and actually go into what our system looks like. So one of the things I'm actually going to point out first is over on the right-hand side, I have these HIE documents, and our system is constantly retrieving information from the HIE. And when you look at, we use the word document, and it is in fact something that is viewable. So I have one of them pulled up here on my screen, and we can look down and see medications and allergies related to that patient, problems, and you'll hear me talk about the word problems a lot, and which is pretty closely correlated to diagnoses, which most people talk about, but the medical world, when it's all broken down into data, actually talks in the language of problems or SNOMED codes. And then procedures, which are also encounters, where we're looking at the history of services provided to individuals. If we take one of these documents and inspect it, then what we see is that behind the scenes is actually full of data. And that is key to some of the pieces that I talk about along the way, because what we do is we take this data behind the scenes, break it down, and identify key pieces. What do we want to pay attention to? What do we don't want to pay attention to? And then is that data actionable or not? For example, I mentioned diabetes before. If it sees that a patient has diabetes, we inspect our own record and say that we don't have diabetes on file. And that's when I know to notify somebody with our automated mechanisms, because we did not have it on file before. Now we do. So let's let somebody know. Our system itself also has intelligence built in, so that I can take one of these documents and do a clinical reconciliation. So I have this button here that when I click it, it is going to do a complete analysis of everything that we just received from the HIE versus what is in our electronic record, and then give me the opportunity to say, well, I want to add this stuff in. So here it's saying that on the left-hand side, this is what your EHR says. Over here on the right-hand side, this is what the HIE says. And in this case, it's saying that I don't see anything new. So we're going to leave the medication piece alone. But I've got everything broken down into medications and medication allergies and problems or diagnoses, diagnosis codes, procedures. But look what happens here on medication allergies. Over here on the right, it's saying that we have a peanut butter allergy. It's recognizing that I don't have a peanut butter allergy in my EHR. So I can click on add and it will automatically bring it over and store that in my EHR. Now, back on our care management dashboard, then, as I mentioned, we are consuming information from the HIE on a real-time basis. Now I'm back where I meant to be. In our care management dashboard, we actually have multiple dashboards, one for engagement, one for outreach, transition, and tailored care management means that someone's consented to participate in the program. And just kind of a little different picture of what Daymark looks like from a care management perspective. If I look at a tailored care management consented map where the participants are actually participating in the program, then it looks like this. And that's real-time updating literally as people say, yes, I want to consent to participate in the program. So people work out of the dashboard. When I first came into here, the provider was set, which would be the assigned care manager for individual. And we end up tying those to brick and mortar locations. And if they want to, they can end up associating that with that location as well. But I've made it global so that I'm looking at everyone. And in here, I can sort anybody in the dashboard. And right from the beginning, these sorting mechanisms I'm using leverages information that we obtained from the HIE. For example, we have our own risk score that we tie to each patient. And I'll show you what that looks like. This particular one has a risk score of 45. And when I open up that patient and look at the risk scores, then it will show me that the Daymark risk score is calculated by 41 emergency department visits in the last 90 days. And each one of those is a point on the risk score. And then facility-based crisis visits, mobile crisis visits, and problem counts and social determinants of health, or HRSN, as some of you might now be calling it. So our SDOH is on a mild, moderate, high scale, and each one of those has a score. So this puts them at very high risk at 45. Now, if we break that down and actually look at what's feeding into this, we have, like I said, 41 ER visits, and we do have a few duplicates that tend to come through when we're looking at that data. I'm not sure if that's the case here, but when I open up the patient, one of the first things I see, in fact, is the ADTV, and we have somebody coming in at 3:08 this morning, as a matter of fact, to Wake Forest Baptist Health, suicidal ideation, and then another 6:30. There's a 6:29 at 21:45 for pain, suicidal also. Feet pain, hand pain. So here we do have somebody that has a great deal that's going on, and most of them are in fact unique occurrences as reported. We also have in here the external CCDs. So I'm going to open up this chart. Then I have the HealthConnex patient summary, but I'm also getting summaries directly from medical institutions too. And I can open one of these up. That's as far as the confidential mode goes into that, because when I open that up, that'll be a real continuity of care document, information that we received from the HIE without modification. So I would see the real information if I went further and opened that up again. The HIE problem list, as I mentioned, like diagnoses, if I look at that, then we see that you have to be careful sometimes in opening something that's up with intentions of saying what it is, because I might come across something that doesn't look familiar to me, and I don't even want to try to pronounce it. But this is what this is what a SNOMED code or a problem looks like, and the description of those problems. And we also bring in vaccinations, so we can see where we're taking the information provided to us and what vaccinations they've received and on what dates. Things we do in the dashboard is we spell out what the comorbid conditions are. So we have our own shorthand that we use for what we've decided is our significant items that we want to look at. And when we hover over these problems, then we can see that this person has hypertension, diabetes, asthma, obesity. And this is not information that our behavioral health staff have reported. This is all information that has been consumed automatically by something running in the background that's inspecting this information from the Health Information Exchange. Over here on the right, we have gaps in care that tell us things like people are missing their annual flu shot. But it goes beyond that, because as a care manager, I might want to organize my workday. Usually my workdays focus a lot on interruptions, the system constantly telling me about new information or getting phone calls from our members. But if I have time, if I want to have a focus, let's say that I want my focus today to be on patients that have diabetes and need a mammogram. Then once I can simply type in diabetes, which it knows is a problem, and a mammogram, which it knows can be a potential gap in care. So it has identified all of these, and we can see by our problems and by our care alerts that they match. So for everyone in the list here, I have diabetes, and we have the gaps in care, such as the missing mammogram. And I can sort on these, seeing the different risks, risk factors associated with those. So I might want to focus on those that have a higher risk. And I'll just mention to Carolyn, is somewhat interesting to see what I have on here is care management acuity assigned to the state. So I can see the correlation between the Daymark risk score and the acuity, which lines up pretty well for the first 4 members. But I have high acuity patients that are low over here on the left-hand side. And I'm not really sure what is driving that until I open it up and see what's calculating the risk score, and see that it's actually the number of COVID conditions and social determinants of health. So it might be the lack of the frequent emergency department utilization that's keeping it from being a higher acuity level at the care management level. So I think I've touched on most of the main points of how we're leveraging the data coming into the system, and actually can cut it short a little bit, because I know that I've seen a number of things pop up. There is one more thing, I'm sorry, I did want to point out. With all of this ADT information coming in, it's coming in real time. And right now, we have 579 different types of alerts, not just ADT alerts, but other types of alerts that have not been acknowledged yet. So when we determine something is important that staff need to acknowledge, then we require them to acknowledge it, and it won't go away until they do. So if I click on that, then I'll get an idea of what we're looking at. And we'll see that on the first screen, all of the alerts are from today, and they're all ED admission alerts, admission or discharge alerts. And my protocol is someone receiving this alert, I would click on it. And from that, I might say that, well, because I know this, I'm going to say that an assessment needs to be done on this date, and I need to update the care plan on this date. And it's going to issue tasks to me for me to follow up. Getting that I'm acknowledging this trigger that I've received. And even as I'm navigating through the dashboard, then I may get alerts let's see if I can, I have mine emulated so that it will cause one to come up as I move around a bit. I believe I have to update my search. So here we have one in real time that comes up saying that someone just been admitted to Duke University Hospital for suicidal ideation. So it's constantly evaluate what's going on, what do I see that's new, and telling me as I'm working, if that's a member of my caseload, you've got something going on right now in case you need to pay attention to this, stop what I'm doing. And list of people working on people that have diabetes and need a mammogram and switch over and to deal with this one patient that it has just been admitted to do. Okay, for that, I'll stop and pause and see if we have any questions.
All right.
Good job.
Thank you, Chair. So you still have the ability to unmute yourselves if you have a question for Jerold at this time. Fantastic use of the data. Great. Thank you, Kim, for answering a lot of questions in the background and putting a lot of the links in.
Someone has asked, can this be used to obtain service orders between an ABA provider and a primary care provider?
Sure, I can explain it.
Yeah. Samantha, you might need to explain that a little bit more.
I just unmuted myself. So when we need authorizations from like Medicaid, Trillium, or the MCOs, we typically have to send in a service order. Like we have to fax it to a primary care provider for the member's primary care provider. And then they have to fax it back to us for us to send in with the authorization. It's basically, I think, stating that the primary care is aware of, you know, the treatment that the member has. I think that's the purpose of it. And I didn't know if the primary care, you know, if they're using the system too, is it something that, you know, we can communicate with them or no?
This is Christy. That sounds like an interesting use case. So I will probably follow up with you after this call to get a little bit more information to see if that's something that could the HIE could be utilized for.
Okay, thank you.
Okay. I don't see another question, but I see some very helpful comments in here. If I'm missing a question, someone please let me know. And again, we are offering one-on-one trainings as well as our training modules. And we placed the email address for you to request those trainings in the chat. Question, anybody? I don't see another one.
I don't think you're missing a question, but I saw a lot of people. So Kenya's going to demo it. I think it's valuable to know that you can also go online and do online trainings at like whenever you want to do them. So your folks could sign up for them and then they'll get a link and then they can self-guide themselves through it so they can become familiar with the tool. And it's always, it's very helpful that they have a resource they can go back to when they want to check in and forgot a piece that they were already trained on if they're going to use the portal. So
very good. We often share those pre-recorded training modules in advance of doing a one-on-one training. So that way we can, like you said, fill in those knowledge gaps. Very good. Thank you so much for that. Am I missing anything? Oh, righty. Let me try to get back to sharing my screen. Well, there we go. We saw your comments, and we know that there are a lot of smaller behavioral health providers that are a bit, I don't know if intimidated is the word, but maybe overwhelmed at the amount of information that you're getting. So again, I want to reiterate that we are available to do one-on-one trainings for you. Want to start just by giving you a high-level overview of some behavioral health statistics that we've been provided by our technical partners over at SAS, just to give a snapshot of the behavioral health providers that are available within the state. Again, this is a working group meeting. So again, if your provider type is not listed here. Feel free to share additional feedback with us in the comment section. But from what we are aware of, the footprint of behavioral health providers across the state encompasses psychiatric hospitals, psychologists, psychiatrists, and counselors. There's over 20,000 behavioral health providers based on the 2015 CDC ratio of psychiatrists and psychologists per 10,000. In addition to that, we have 2,480 organizations that have submitted participation agreements to the Health Information Exchange Authority. And there are 243 behavioral health organizations that are live with us that represent 100 different electronic medical records or electronic health records. Of that, 61 EMRs have 5 or less participants. So again, we do realize that many of you have very few state-funded patients. In addition to that, the top 10 EMRs account for 70% of the participants, and we have 232 participants that have not shared with us their EMR, or they have no EMR or EHR to date. And we do know that having that EMR is a necessary step to connecting to the Health Information Exchange. So all providers are subject to the HIE Act, and they should have moved forward with connecting by January 1 of this year. And this includes behavioral health providers, licensed clinical social workers, and as well as psychiatrists. If you'll remember, some of you back in 2019, House Bill 70 passed on June the 6th of that year, wherein there were 10 classes of providers that were called out as voluntary. And those include community-based long-term service and support providers, including personal care, private duty, nursing, home health, hospice care providers, intellectual and developmental disabilities, including service support, day support, and supportive living providers, our community alternatives for disabled adults as well as for children, innovation providers, eye and vision providers, speech, language, and hearing, occupational and physical therapy, durable medical equipment, non-emergency and emergency medical transportation, and our local education agencies and school-based health providers. So with that, those providers do have the ability as voluntary providers to participate by completing a full participation agreement. And the caveat to that is that they do not have to connect to the HIE with an EMR in order to send over their data, but they do have the ability to utilize that data for care coordination. Under Medicaid tailored plans, AMH plus practices and CMAs will be expected to consume, analyze, and apply data. I think both Carolyn and Jerold gave great examples of how they're doing that, and they use that to support critical tailored care management program functions.
Hello? Stay in the back.
Teletown Hall in August of 2022, wherein we've linked the recording as well as the slide deck from that presentation. But it's also important to note, as we big up our NC Notify service, to note that those admission, discharge, and transfer information will be used to identify when members are transitioning into and out of the hospital and trigger systemic, clinically appropriate processes to support care transitions. So what is your first step? There's two main things that you have to do. And most of you, if you're on this call, you've already taken that plunge in completing that participation agreement. But again, I mentioned that we have several providers who don't have EMRs as of yet. So you do have to have an EHR that can send continuity of care documents or HL7 version 2 or higher messages, as well as you have to have a participation agreement that is executed. We do have two forms of participation agreement. That full participation agreement is aligned with the eHealth Exchange Exchange Data Use and Reciprocal Support Agreement, known as DERSA, which allows providers to fully use any of our current services and any future value-added services that we may add. And it satisfies the state requirement to submit both that clinical and demographic data to the HIE. If you have a full participation agreement, you may submit data through a one-way unidirectional connection, or if your EHR has the capability, you might also submit data through a bidirectional connection, which would allow you to view that data, which normally would populate that web-based clinical portal. You'll be able to access that directly within your EMR. If that's a service that you're interested in, bidirectionality, you would have to reach out to your EMR to determine if they have the ability to do that integration. Full participants with unidirectional, that's that one-way connection, will have access to that web-based clinical portal, which I'm going to demo for you today. In addition to that, we have our submission-only participation agreement that enables a provider, again, to submit both that clinical and demographic data that's required by that HIE Act that you have to send to be compliant. However, this submission-only participation agreement prohibits all other data exchange services, including the querying of our clinical portal, any of our event notifications, our public health registries, any of our services. So participants with the submission-only agreement should consult with their legal counsel prior to sending data that does not pertain to healthcare services paid for with state funds pursuant to the HIE Act. Someone needs to mute themselves. I think you're having lunch and we can hear you in the background. In addition to that, being able to only submit state-funded data will also depend on. So if you have signed a submission-only participation agreement, key conversation for you to have with your EHR vendor is, are they able to implement data filtering? Because that is a requirement for that submission-only participation agreement. And all righty. Either participation agreement that you sign, would you please so kindly send it to hiea@nc.gov, and it will be processed by our provider relations team. So our connection process, we have 7 steps. First, again, once you sign either participation agreement, you'll receive an emailed welcome packet that will include some patient education materials, talking points, FAQs. Carolyn mentioned there's an order form, so you can order those patient education materials, both in English and Spanish. And I always like to plug our website where we have our most up-to-date FAQs. And also, when you get that follow-up email on next Wednesday, we do plan to include a link for you to register for our upcoming teletown hall. That will be on July the 12th, wherein you'll get a higher level view into our website. In addition to that, step number 2 is once you have that executed participation agreement, you can request portal credentials. So that's the great thing, because you don't have to wait until you're live and sending your data in order to start utilizing our services. But again, that's only available to our providers that have signed full participation agreements with us. You are as step 3 indicates, available for provider training. We do have those web-based, training modules, as well as we have 3 awesome members of our outreach team that are available to do training either one-on-one or with you and your team. And step 4, with the intake process, you have the HIE team will contact participants to initiate this process for connection. And it could take, just a point of reference, it could take several months before a participant is invited to begin the intake process. So don't be alarmed, which is again why during that waiting period, you can begin using those training modules and reaching out to the outreach team to get training for your team while you're waiting. Step 5, our connection, development, and testing. Here we leverage production data to validate message content and format against the data target, which I'm going to go over in a moment. Number 6, live in production. So you will receive an email again from our provider relations team once you're live. Now, I want to reference back to step 1. That welcome packet has materials for prior to going live, as well as there's a separate set of materials that you're able to utilize once you have gone live. So that welcome packet, again, is a vital resource that you'll use throughout your iteration as participants with the Health Information Exchange. And lastly, step 7, operations and support. Not only do you have support from us at the HIE, but you have ongoing technical support from our team members at the SAS Help Desk, and they can be reached at HIE support@sas.com or by calling 919-531-2700. So I mentioned that I was going to be sharing the behavioral health data target. So we often get questions from behavioral health providers. What will I be sending? What type of information does the HIE want to see from me? Here you have linked at the top, reporting and technical specifications document. But if you'll take a look at the data target, the data elements listed in green, here you'll be asked to send your patient ID, name, date of birth, address, phone number, language, race, ethnicity, gender. And that second line, you see that date of visit, the visit number. If you haven't been assigned a visit number, a lot of that will be done by our technology partners. The reason for the visit, level of care, location of the visit, care team members, problems, and medications. And give me one moment. There was something I wanted to share. I'll go back and say that later. I want to make sure I don't forget some of my talking points. So one thing I do want to clarify is that we understand that there are instances when collecting some of the information is not applicable to the care provided. So we aim to meet you where you are. So we do ask that you send us the most robust data set that you're capable of sending with regards to our data target. Did I miss anything here?
No, but you got several people saying we need to slow down.
Okay. Right. So what can be shared? Again, most behavioral health information is permitted for you to share to the Health Information Exchange. Although participants, we do ask that you not submit Part 2 data or psychotherapy notes. And at the bottom of this particular slide, I'm not going to read it to you, but you do have the SAMHSA definition of the HIPAA privacy rule definition of a psychotherapy note at the bottom. In addition to you're not being able to submit your data to within NC HealthConnex, we do allow you to send those 2 types of data via direct secure messaging. That's a separate service, again, that sits within our clinical portal that I will be demoing for you in just a few moments. And the provider sending the message must comply with applicable law and obtain any prior consent from the patient, prior authorization before submitting any data via direct secure messaging. Is that clear? Sorry if I'm speaking too fast for you all. Okay, so with regards to our policies and procedures, we do have linked for you here our privacy and security policy. In this particular side, you have the user access policy, as well as the behavioral health sensitive data policy and our opt-out information. NC HealthConnex is secure and private network. It follows the highest information security standards available. The information is always sent over an encrypted and secure network, and it's private. It's compliant with both federal and state privacy and security laws. The information that identifies a patient will not be sold in any way or shared with anyone other than an authorized healthcare provider or organizations that have entered into a HIPAA compliant data sharing agreement.
Yeah.
I'm happy to address any questions right now.
Okay, so we have a question from Christine Diggs. To clarify, you do not want diagnosis?
We do want diagnosis.
It's, so on the list, it's problems, it's listed as.
It's listed as problems.
So problems is the diagnosis.
Okay. Thank you for clarifying that, Carolyn.
One other question. Will the system remain the same when Aetna takes the contract?
State health plan and, the HIE is not privy to what is going on with the state health plan and the switch from Blue Cross Blue Shield to Aetna. So it's not something we can comment on right now.
And I was just wanting to make sure that is the sound.
Oh, but it can be heard.
Okay.
And did y'all hear Chrissy's comment about Aetna? I'm not sure if they heard that.
There's another follow-up comment to that, Chrissy. It says, I'm assuming for state health plan.
Yes, for state health plan, many of you may or may not know that the state health plan is newly contracted with Aetna and we're moving away from Blue Cross Blue Shield. We're not privy into what that transition is going to look like. But as far as I know today, does not change the requirements for reporting under the HIE Act. So if you are in state health plan network per the law, you would still be required to participate and submit data to the HIE unless you're a voluntary provider. But other than the transition from Blue Cross to Aetna, we're not privy to that.
Got it. So our privacy and security policy is such that the Health Information Exchange Authority recognizes the importance of healthcare providers having access to behavioral health and treatment records in their daily healthcare practice. And again, I goes to Jerold and Carolyn for really giving a real-time visual into that. We also recognize the importance of behavioral health providers having access to their patients' physical health records to enable whole person care. Only certain entities such as healthcare providers who sign contracts with the HIEA, who have a treatment relationship with the patient, will be able to access that patient's medical information through HealthConnex. Patients' data may be provided to third parties who've entered into contracts with the HIE for limited purposes. For example, the Department of Public Health for immunizations. These contracts ensure that all relevant privacy statutes and regulations are followed in how health information is viewed, used, and shared. The HIEA has the power to audit the use of patient information by each participating practice and each third party to ensure the law is being followed. I also mentioned earlier our sensitive data policy, but it bears repeating. Federal laws and regulations prevent the HIEA from receiving and or managing certain types of mental health or substance use treatment data. Under federal regulation 42 CFR Part 2, it prohibits certain healthcare providers who participate in that program from disclosing data that would identify a patient as having a substance use disorder, unless the regulations specifically allow the disclosure. Regardless of patient consent at this time, substance use disorder information cannot be sent to NC HealthConnex. If you're unsure, I would recommend that you consult with your legal counsel to determine if you are a federally assisted drug abuse program that must comply with 42 CFR Part 2. And again, our sensitive data policy is such that mental health providers should not send us psychotherapy notes as defined by HIPAA, and you have that definition again on a previous slide. With regards to our user access policy, we take our role as data stewards seriously and expect that our participants will as well. All use is role-based access controls, access levels for each authorized user. The participant account administrator is the one that's responsible for assigning the roles to the users at your practice. And again, the health desk is the one who will provide those credentials to you. And they can again be reached at hiesupport@sets.com. And we have linked here for you the reference guide that is designed to assist participant account administrators in that assigning of user accounts. And access to patient information is granted if you have an established treatment relationship with a patient. Now, with regards to patient education and our opt-out process, again, those materials are of such that we have a sample notice of privacy practice, we have fact sheets, talking points, FAQs, we have sample employee newsletters, leadership emails, and there's an order form where you can have that order those trifold brochures in both English and Spanish. And patients will have the right, as Carolyn explained earlier, to opt out of having their information shared with other providers. But I'll go over a little bit more about that opt-out process in just a moment. And you also have linked here additional information for the patients on this particular slide, as well as a link to our website here, so you'll have more information about our policies. But North Carolina is an opt-out state, which we have been since 2012. Which means patients have the right to opt out of their health information being shared within the health information to another provider. And the health information exchange for HIPAA-approved treatment, payment, and operation purposes across all information exchanges, both public and private. The HIE Act requires participating healthcare providers to provide both those education materials on the benefit of health information exchange, as well as their right to opt out of the health information exchange. So again, you have that brochure. And then also, they also have the right to rescind their opt-out. So that same form that they send in if they want to opt out, that's the form that they will send in. And that's an important talking point, because oftentimes patients don't realize when they opt out at one provider, it's opting them out at all other providers, which means that they won't have the ability, as Christy stated earlier, their information is suppressed from view so that no other provider will be able to see them. So if they were to get in a car accident, say, and they were at the emergency department, they would if the hospital needed to see their health information within the HIE, they wouldn't have the ability to see anything. So that is another reason why many patients rescind their opt-out, because they didn't realize that it would block someone that they would want to see that data. Sure.
So there was a question in the chat that said, on the private practice, does each provider in the practice need access to the HIE? The providers are contractors, not employees.
So that would be an individual decision at your practice. If they would like access, they could have access under your full participation agreement, but they don't have to have access. It would be completely up to those providers if they felt that the information available was something that they would like to utilize to coordinate care for their patients. I thought I saw, did another question come in, or was that a comment?
Second part of that question I read.
Okay. All right. So with that, I want to give a very high level overview of our event notification service, NC Notify. Again, that is our event notification service, wherein subscribers establish their cohort of patients for whom they want to receive alerts. And all clinical data feeds come into the HIE are monitored for matching event or clinical data of interest to that subscriber. So again, you get to filter that information out. These events can then be published directly to your subscriber within the clinical portal. You receive those notification of events or data that match that patient via preferred method. So as Carolyn stated, you can get batch notification files in delimited or HL7 format. You can get near real-time notifications via HL7 messages, or you can get web-based access to the NC Notify dashboard. So here you have a visual into that NC Notify dashboard. Organizations providing tailored care management will be required to have access to ADT data that identifies when members are transitioned into or out of an emergency department or hospital in real time or near real time. Organizations providing tailored care management will be responsible for ensuring there's a systemic, clinically appropriate process in place to support care transitions, with designated care managers staffing reporting to certain high-risk ADT alert, including real-time, within minutes or hours, responses to emergency department visit notification, same day or next day outreach for designated high-risk members, and additional outreach within several days for those discharged from a hospital or emergency department to confirm outpatient needs are being addressed. So what notifications are there available within NC HealthConnex? She said tailored care management is required. Is that new? So again, admission, discharge, or transfer notifications of any visit within NC HealthConnex network is base and plus tier providers are able to utilize that. COVID-19 notifications are available to our plus tier subscribers, wherein notifications of COVID-19 tests and the results will display within their dashboard. Notification of at least 2 ED visits in 90 days or at least 4 inpatient admissions in 12 months is available for high utilizer alerts for plus tier. Dental alerts also for plus tier are when patients visit the emergency department for dental care. Another plus tiers notification is when care team member change alert. So providers are informed when new organizations have subscribed to their patient. Diabetes alerts, again, for plus tier, providers are alerted upon a new diabetes or pre-diabetes diagnoses for patients that they're monitoring. And the last notification is that chronic care management alert, where providers receive an alert when a patient meets the Center for Medicare and Medicaid Services chronic care management services criteria. We do have a web-based enrollment form that's online. And this form can be found under the NC Notify tab on our main page of the HIE website. To enroll in NC Notify, your organization must have a full participation agreement. And once signed and executed, you can move forward and utilize this service. And for more information, you can feel free to email us at hiea@nc.gov. And one of our NC Notify analysts will then work with you to ensure that you have accurate understanding of this particular service.
Just FYI for the group, Kim has dropped some information into the chat, a link where you can learn more about the tailored care plan.
So
Some valuable information can be found there.
very good. Thank you so much. Are there any additional questions before I transition into demoing the clinical portal? All righty. So I'm going to go ahead and again move forward with the demo of the clinical portal so that we have adequate time to get through this portion, because I know many of you have been waiting for that. So you will access the clinical portal again from our website. And again, if you join us on July the 12th, when we have our teletown hall, our communications person will show you where we have that linked on our website. But today I'm going straight to this demo environment. And the first thing you'll see is a green notice box wherein we have real-time updates. You see here that NC Notify Plus is undergoing some scheduled maintenance that happened on June the 27th, and that was from 6 to 8. Also, they had some scheduled maintenance on Wednesday the 28th from 9 to noon. There's a message in here for participant account administrators to attest to that Q2 quarterly user audit. There was a change in the printing functionality, and then there's some additional unparsed CCDAs that may be available to you as well. Here in the middle is where you will enter your credentials that are obtained, again, from our technical partners at SAS by emailing HIEsupport@sas.com, where they'll work with you to obtain individual login credentials for the members of your team. Again, that has to be submitted by the participant account administrator. And before logging in, I like to review our login agreement. Again, this is a demo environment similar to what Jerold shared, where there's no actual patient data that will be displayed here. And it states you'll only access patient information for treatment, payment, or healthcare operation purposes as defined by HIPAA and as permitted by your participation agreement. You understand that all access to patient information is monitored and recorded. You'll safeguard patient information from any inappropriate disclosure. You'll immediately report any suspected breach of patient information to your supervisors if applicable, as well as report any suspected breach of patient information to the HIEA, the help desk, as well as legal, and those email addresses are provided for you there. And lastly, you will not share your user ID or password with anyone. So with that, we're going to log in. Okay, so now you have displayed our disclaimer. Again, we like to reiterate under confidentiality notice for alcohol and drug abuse information that we do not, that you cannot send us 42 CFR Part 2 data, nor can you not send us psychotherapy notes. And lastly, what is your responsibility as a utilizer of our platform? If you agree, you'll be taken into the patient search, which is the default page, into our clinical portal. If you disagree, it will take you out and you won't be given the ability to go any further. So you have two ways to search for a patient. You can search by a medical record number if you have one, and wherever you obtain that medical record number, the associated facility that assigned that number can be entered in the space provided to the right of that. And you can also search by demographics. As few as 2 demographics are required. I always recommend that you enter as much as you have to ensure that, again, the correct patient record is open. Again, because this is demo environment, it's only going to display one patient in the search results. But if you have a patient with a common name, it may display several. So again, you want to be mindful of what's displayed when you do get to the search results. The identifiers, gender, date of birth, and address, and to ensure that when you do click on the record, it's the accurate patient that you want to display. From here, you have to declare your relationship with the patient in order to break the seal and for that record, the clinical information to be displayed for you. Your 4 reasons to select from are either a clinician treating the patient, you're doing care coordination, you're conducting a quality audit check, or you're conducting a privacy or administrative audit. For the purpose of this demo, we're conducting a quality audit check. And from there, you'll declare your relationship. And that will open up or break the seal and allow you access into the patient record. Before looking at the chart book and the information that's displayed, I do want to start to the very top in the blue ribbon, that's the bar that's at the top, where participant account administrators will have the ability. Again, this is where you can submit your user account management spreadsheet. Again, that's explained for you in your participant account administrator reference guide. But here's where you will submit the users who will then have access at your facility. And then where I have a table displayed here of my users, their ID, their email, their assigned roles, because again, not everyone will have the same level of access. Some users have clinical access, some participant account administrators are the participant account administrator only, or such as myself, you could be a participant account administrator and have clinical access. And the other roles, again, are explained in that user account in that guide that you have. And this is where you will attest to the quarterly user audit. So once the participant account administrator reviews their particular table for their practice, they will scroll to the very bottom and attest quarterly. So if you haven't done so, again, attesting to the audit activity, the information provided in the portal is around the user activity is accurate to the best of your knowledge. You or your designee have requested that the SAS help desk make any necessary changes, which that's important if you've had any team members to leave and you've needed to deactivate their account so they don't have access to this information once they leave. And lastly, you've reviewed the user activity information and confirmed that it's acceptable under the participation agreement and applicable laws. And in the case of suspicious or any other activity, then all user anomalies have been or will be investigated and appropriate action taken as necessary. So once you do that, you'll enter your name. If you have more than one participant account administrator, the first one who attests will attest for your practice. So you do want to communicate with each other. And it's once you review that, and then you'll click OK, and then your attestation will be submitted over to our team members at SAS. We won't go back to the patient search because that's where it defaults to at the beginning. But if you remember, I shared with you direct secure messaging. Just want to reiterate, you cannot send 42 CFR Part 2 or psychotherapy notes within the clinical portal. But again, with patient consent, you are allowed to send those two forms of data within the direct secure messaging service, which is what you have displayed for you here. It looks very much like an email address. Here you would compose. If you click on to, it will display the ability for you to search for clinicians. To date, I believe we have over 25,000 providers in our provider directory. So you can enter a last name and you can search that way. And you'll see that all the providers that have that last name who have direct secure messaging accounts with us will display for you. All righty.
Question says, if we have never accessed the portal, are we required to attest quarterly? And then secondly, are we required to use the portal?
Great question. And the answer to that is you are not required to utilize the clinical portal. It's offered as a service to our participants that have full participation agreements. And if you're not using the clinical portal, I don't believe that you have to complete the.
If you have an account signed to you, you will receive the audit. You need to complete the audit and say we have not accessed it. So if you have a credential, you will receive the audit. So you should just let them know that you have not accessed it.
There you go. So if you haven't, you still need to complete it. There you go. Thank you for clarifying that, Christy. Any more questions?
Okay.
All right. Thank you, Kim. And so again, that is what our direct secure messaging service looks like within the clinical portal. So next to that, we have our clinician tools where you will have the ability to create lists. You can also view any recent patients that you have searched for within the clinical portal. Those lists are unique to whatever you would like to create. If you want to, again, as Jerold mentioned, you may want to create a list of your patients who have suicidal ideation, or you may want to make a list of your patients who are high utilizers of the emergency department. It's completely up to you how you'd like to create those lists and how you'd like to monitor those particular patient relationships. Right. The other NC Notified is not within the demo environment, but again, as we mentioned to you earlier, if you'd like additional training about NC Notified or any of our services, feel free to reach out to us at hiea@nc.gov, and we'll be happy to schedule you a one-on-one training on NC Notify. I went out further than I wanted to, so I'm going to go back here. Our controlled substance reporting system is also can be integrated into the clinical portal. So if you are a prescriber of certain opioids, you do have the ability to, there's a list of steps that you have to follow in order to request integration, but you do have the ability to utilize that, which would prevent you from having to log into CSRS as a separate system. You could view that directly within NC HealthConnex. So with that, I'm going to take a look at the types of information that you have available. I think Jerold did an awesome job of explaining to you what types of information you will then have the ability to access. But if you see here in this first line, you have that patient's information. Again, there's provided their age, their gender, date of birth, their phone number is also displayed for you, and their address. And then over to the far right, you see there's some icons that if you hover over them, it will explain to you what each icon means. So you do hover to discover, and if you click on them, it will open an additional pop-up window to give you more information. And then if you go even further than those icons to the far right, I often get questions about printing functionality, downloading of any of documents within the clinical portal. That little section is where those three dots, that ellipses, is where you will then be able to view. It automatically defaults to HTML, but you should have the ability from this drop down, the very first one, where you can change that to either a PDF or to a continuity of care document. I think Jerold gave you a view of the continuity of care document, and this is what they use to download in order to feed it into their EMR. Not all EMRs have the ability to do that, but again, I want to just, if it will display, give you a visual into that. It's a little delay. I'll do that. So that gives you an idea into what that CCD looks like. The PDF view is the one. You give it just a moment, it will display for you. To me, this is the cleanest view. Just give it a moment. Sometimes it takes a while for the page to completely load. But right beside that, if you'll see there where it says report, patient summary report, there's another drop down where you can view it in the classic view, or you can view the expanded view. The classic view, again, is going to display one continuity of care document at the time, where you see that's 46 pages. But if you click on expanded, which is right below that, it will bring in all the continuity of care documents that we have on this particular patient. The patient page number, as you notice here, went up to 114 pages. And again, this is where you can rotate, you can view it in more than one page. Here's where you have the ability to download and also to print. You can print in whole or in part. Another good thing about this PDF view is that with Control F, if you're in a pinch for time and you're trying to find a particular thing, you can, or a particular medication or a particular problem, with Control F, you can type in that information and it will take you to everywhere that particular word occurs in this document. So those are some little tips for when you want to print that continuity of care document. So from your summary, you have displayed both allergies, medication, CCDs, and other documents, general lab results, other results and notes, and diagnoses. Under each section, there's four or five? Five sections underneath. And with that, you have the ability to also sort how they are displayed for you. So if you want to view older information, if you know the date, if you'll go here to the last updated and you'll click on that arrow, it will change how that information displays for you. Also, when you see the ellipses, if you click on those, it will display additional information. It's also important to note that what is displayed here is what was sent to us. So often we hear from providers that something may be that they're looking for might be missing. If it's not displayed, it's because it was not sent to us. Or that provider may not be connected yet. That could be another issue. So there could be several reasons as to why you don't see that information. Under medication section, you'll notice here there's next in blue, and all of the order names of the medication are in blue. That indicates that they're hyperlinked. Again, when you see something in blue, it's hyperlinked, so you can click on that for more information. Under general labs, you see that there's some information that's in red. Anytime you see something in red, it indicates that there's an abnormality or something outside of the normal range. Like Jerold, not a clinician, now I don't want to start trying to mispronounce a lot of things, but if you'll click on them, again, additional details regarding that information will be displayed for you under that particular item. Want to go down to the continuity of care documents. Another one of my favorite displays here where you're able to view this continuity of care document for this particular patient. And you're, again, another clean view where you're given the demographic information to the top, that patient, date of birth, preferred language, any contact information is there. Continue to scroll down, you'll see that document ID, so forth and so on. Emergency contact, again, if it was provided, it will be displayed. If not, that means there'll be no information there for you. And then you'll see that table of contents. Everything in this table of contents, again, is hyperlinked. So you don't have to spend valuable time scrolling down, hunting for information. If you're looking for the plan of treatment or the progress notes, you can click directly on that information and it will take you to that section. And if you want to go back to the top for your table of contents, you can click on that header and it will take you right back to the top. I did forget to mention again the help at the top ribbon. If you hover over that, again, that number that I've shared with you before to our team at SAS, as well as their email address is there. But if you click on that, it takes you to the training and resources section of our website, wherein again, we have our pre-recorded training modules that if you would like to utilize those prior to reaching out for a one-on-one training, you do have the ability to do that. And with that, with just 5 minutes left, I want to stop and see if there's any questions and allow anyone in the room to fill in any gaps of anything that I may have failed to mention or needed to clarify. Christy Burrows, come on down.
Just in the last 5 minutes, I just want to thank everyone for joining us this afternoon. I think Carolyn and Jerold did a really great job of demonstrating the value when you have the time and the resources to really focus on incorporating this data into your workflow. I think for those providers in the chat who still feel overwhelmed around the requirements and how to incorporate this data into your everyday practice, I would highly encourage you to reach out to our outreach team and schedule some one-on-one time so they can, really explain it to you and make you feel more comfortable with what the HIE has to offer that can be really a tool in your toolbox to provide better patient care. With that said, I know Robin knows because I've talked to the Joint Insurance Committee several times. The advisory board spent a great deal of time in 2021 coming up with comprehensive language around regulatory changes to the HIE Act around compliance. And so some of those changes are still in draft form. No bill has been introduced, but they would take a look at thresholds of claims data submitted on state-funded patients to that might provide exceptions for providers who really do not see a large Medicaid or a large state health plan population and where those providers who are especially financially challenged. So I just wanted to say there has been a lot of work put into that. We are still working hard to get our legislators time on their schedules so we can have meaningful conversations with them. But I just want to let you all know who remain concerned about the requirements that our team is here to help continue to educate. Obviously, we are advocating for you to give us a shot and give it a chance because we think you'll find that it can help improve the care that you're currently offering. But we also recognize that there are just some hardships that are going to be hard to overcome, and we're working hard on that end as well.
All right. Thank you, everyone, for joining, and have a great day.